Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, everyone. Thank you for joining Home Healthcare News, Axxess, and our expert provider panel, who will share their reaction and strategies to address CMS's calendar year 2023 Home Health Final Rule. Welcome. We appreciate you taking the time today. We hope this is going to be a very interesting dialogue and you'll really get a lot out of it. So we'll be talking about CMS's calendar year 2023 Home Health Final Rule. So we're not going to focus as much on the detail of the rule, but rather the actions that these three leaders and their organizations are taking now in 2023 and longer term to position themselves to manage their businesses, serve more patients in the home, and succeed under the final rule framework. So welcome, I'm Deb Hoyt. I'm Senior Vice President, Public Policy at Axxess. It's my pleasure to welcome our three panelists. Mike Johnson. Mike is Practice President for both the Home Health and Hospice practices at Beata Home Health Care. Stacy Smith, Vice President, Public Affairs for Accent Care. And Evan Reinhardt. Evan's Executive Director of the Indiana and the Kentucky Associations for Home and Hospice Care. And he's also the chairman of the Council of State Association Executives. So welcome to each of you.
Thanks, glad to be here, Deb.
Thanks so much for having me, Deb.
Oh, my pleasure. We're really glad. Thank you for taking the time today. Okay, so Mike, let's begin with you. CMS finalized a permanent 7.85% cut to the Medicare home health services in the 2023 Home Health Prospective Payment System Final Rule. CMS acknowledged also that its significant reimbursement cut would create a hardship for providers. So CMS will be phasing in half of the reduction, which is 3.925% for calendar year 2023. So Mike, I know you're very involved with this now. Tell us a little bit about your role at Beata, your organization's geographic coverage area and service lines, and what these rate reductions mean to you and your operational strategy moving into 2023. And that's also a time when home health value-based purchasing is going into effect. So Mike?
Well, again, thanks for having me. This is something that's been on the minds of myself, my teams, and everybody who's listening to this webinar. Before I go into kind of what we're thinking about and looking to do, I will give you a little bit of the background. So I'm the president for both the home health and the hospice practices at Beata. I've been at Beata about 13 and a half years. I've been leading the home health practice for 8 years. Right, so have had the pleasure of getting ready for PDGM and rolling all of that out. And then just in the last 2 years, I was asked to step in and provide leadership in our hospice practice. And some of that is to just help weave a continuum of care together, which is easier said than done, just because you have the services. But I'll talk about that a little bit later. We are, for the home health practice, we're about 100 offices. We're spread across about 23 states within the U.S. And Hawaii, so mainland and Hawaii. We have what's probably the number that I'm most interested in, that I think about on a regular basis, is how many patients, how many people are we taking care of every day? Right? I can give you my revenue numbers, I can give you all the other stuff, but we're here to take care of patients. So we have an average daily census of about 25,000 patients every day. And so when things like the Medicare cut start coming, I start thinking about the impact on 25,000 people. Just our organization, and for everybody on here, we put our ADC together. We're taking care of hundreds of thousands of patients, and we take that responsibility very seriously. For the hospice practice, it's a little smaller. We're 20 offices in 7 states, active daily census of about 1,300 clients, but growing. And so I can talk a little bit about sort of how we're thinking about home health and hospice together. It's actually part of the strategy, but I'll come back to that a little bit later. I think what I would say to answer the question about how we're thinking about operational impact is, let's first be really clear that we got a cut. CMS will say it was a 7% bump. It wasn't. I mean, you can do the math, but we got a cut because inflation, there's all sorts of external pressures. And so that's the reality. The good news, and what I do appreciate from CMS, is they're phasing in the cuts. And so it really, the the cut that we got is significant. So let's also be clear about that. Take 2 chunks of it. What we're looking at is we'll take what we can get. I still think the cut was not necessary, but we've got some time now because we were planning some pretty significant changes that we're not changing our strategy at all. But what I feel fortunate about, and again grateful for, is we've got 12 months now to get where we were going to probably have to get in 12 weeks, right? In terms of decisions that we would make. And so let me talk a little bit about those. For a little bit more context, let's also remember that managed care penetration continues to increase, and the reimbursement by Medicare Advantage payers, for the most part, doesn't meet oftentimes doesn't meet our costs. It's significantly less than we get paid for Medicare, and so we already had that cost pressure, and that's not going to change. And so with Medicare cut, it actually adds, I think, a little bit more weight to the severity of the issue. So, but we've been trying to plan for that as well. The other thing I want to point out is, as I mentioned before, we've got cost pressures. We all have got cost pressures. Gas prices, thank goodness they've come down a little bit, but they're still fairly high. Inflation seems to be easing, but it's not where it was a year or 2 ago. And one of the things that we all are seeing is that the cost of doing business has gone up, supplies, employee wages. And I'm not sure if you saw the news, but one thing that caught my eye is Kaiser Permanente nurses out in California just negotiated, the union negotiated a 22.5% pay increase. I mean, which I'm happy for the nurses, but for the people trying to run the business and keep the doors open, that's a real, it almost becomes an existential challenge. So with those in place, here's a couple things that we're doing, and then I'll turn it back to you, Deb. We're really focusing, we were already going to do that, but we're focusing more and more on what things can we centralize? What things can we be more efficient with? Managing physician, because we used to do everything out of each office, and we're slowly but saying, can we do coding centrally? Can we do orders management centrally? And we've been on that path. We're going to accelerate that. One, it's more efficient from a cost perspective, but 2, it gives the folks in the offices and the clients and the clinicians in the field more time with their patients. So our strategy is we have to do things that help people spend more time with people, because that's what will make sure that our clinical outcomes don't come down. And then the other piece is to work with CMS and say, what kind of flexibility can you give us in terms of how we deliver care, virtual visits, telehealth, and be reimbursed for those, because we can do it more efficiently, but we needed some more tools, and we've had a chance to use some of those, I think, with good effect. And so those would be the things that I'd say are kind of top of mind for us as we move into what it's going to be, I think, successive years of payment cuts.
Thanks, Mike. You know, the challenges are vast, and I think as we get through this discussion, we'll try to see exactly how we can address some of those, but it sounds like you're on your way. I'm really glad that Bayada is not wasting any time to get moving on its strategy for 2023 and beyond. Thank you for that. So Stacey, let's move on to you. So Axxess Care and you personally have been highly active at the federal level over many months, advocating against CMS's proposed cuts alongside our national associations and other industry leaders. So CMS's 1-year phase-in for 2023 recognizes the intense level of advocacy work that was achieved by our national organizations, and we greatly appreciate that. Yet it really does nothing to mitigate the long-term impact of imposing a negative 7.85% reduction to the home health and home-based payment amount by year 2024. So Stacey, to address the significant flaws in CMS's approach in measuring PDGM payment budget neutrality, want to hear a little bit from you on that. And specifically, what's Axxess Care's strategy on continued advocacy with congressional leaders to get a delay in the payment reductions for 2023 in the last final weeks of the congressional session? And where do we stand as an industry on a whole in terms of advocacy?
Yeah, thank you, Deb. I appreciate it. And I think, as Michael and Evan and you, spending a lot of time in DC, pushing back against this proposed rule. I think, the outcome of the final rule, while, as Michael said, it was, it's still a cut. And I think what everyone needs to understand is that top line number of aggregate Medicare spending increasing by 0.7%. When you really get into the meat of the rule, base payment cut is 1%. It's a 1% cut, and you go in state by state. We've got, the one state that has, on average, I think it's looking at like Montana's 3.5% cut. So it varies. So from the advocacy perspective, I think, this has been going on for years. I mean, Evan can, attest to this, but I mean, this, started with HHGM, and then it's rolled into PDGM. And it's, I think, it has evolved over the years, and I think there's a greater understanding of the payment model. Unfortunately, there's some real differences between what we believe the intent of the statute is and how CMS is interpreting the law. And so as it relates to advocacy, let's talk a little bit about going into the rule during the proposed rule and where we are. I think that the national trade associations, companies like Biata, Evan with Indiana Association, Kentucky, and Axxess, and all of our other partners really tried to emphasize both on the Hill and with CMS as that the way that they were measuring budget neutrality was not correct, is incorrect. Because really what they're doing and what they've demonstrated is that they are applying post-2020 behavior, which is PDGM. They're applying that behavior and then calculating budget neutrality using pre-2020 payment reimbursement model, which it does not make any kind of sense, and it was not congressional intent. So a lot of our efforts were focused on that going into the rule, knowing that we were bearing down this large cut. We were, I guess you could say, successful with the efforts, is that they did say that there would be hardship if they had applied the entire permanent adjustment in 1 year. So they're going to phase that in. But if you look at, the details, we're really seeing, almost a 4% cut next year. It'll be bumped up to 7.85. And then we've got these cascading adjustments that are coming, these temporary adjustments. It's piled up to be $6 billion, right, that they've identified so far. And when you look at a $17 billion spend in a program, you just wonder, where they're going to how they're going to recapture this money, especially as more and more services go into MA and that fee-for-service side comes down smaller and smaller. So, the rule came out, and I think, everyone's pivoted very quickly. We have a great champion in Senator Debbie Stabenow and Senator Susan Collins, and with our House sponsors, of our bill with Representatives Buchanan and Sewell. Senator Stabenow acted very quickly and has, we have draft amended language that would call for a 1-year delay, along with some additional transparency measures to try to hopefully get that data out of CMS so we can, effectively analyze the methodology they were using, because as it stands now, they did not meet that standard in the rulemaking process. So, we are hopeful that if we were to be successful in a 1-year delay, that we could get, rolling into next Congress, hearings and some meaningful discussions with CMS, and then try to get legislative action on having a permanent fix on this, because there obviously is there's a disconnect between congressional intent and how CMS is interpreting the law. And, every member we've spoken to who voted for this measure, their intent was never to cut home health by 20%, but yet that's what we're seeing. So as it relates to immediate action, I think anyone on the call can help in this effort. We have 3 weeks. We are under a continuing resolution until December 16th. They're going to extend that out for a week to December 23rd. They'll start the negotiations on what will go in that end of year package. I think we're getting every indication that we're not going to just do fund the government for another year, that we are going to have a package. But it's really going to be up to the leadership and in the House and Senate to include that 1-year delay. Senator Stabenow is pushing very hard, but we've got to convince what we call the 4 corners, the Speaker and Minority Leader in the House, and Majority Leader Schumer, Minority Leader McConnell, that this provision is desperately needed. And I think, CMS was clever to an extent when they released that top line number, because the immediate reaction from the Hill was, oh, you guys are fine. You guys got an increase, you'll be fine. They're phasing this in. But, like they say, the devil's in the details, and the details are pretty scary. And I think it's the amount of uncertainty that it presents to the sector moving forward when you have these kind of looming cuts in the future.
Thanks for breaking that down. That, it's complex, but as you said, it's something that we're taking in pieces. So two things: the Partnership for Quality Home Health Care and NAC, the National Association for Home Care and Hospice, have really worked together very closely on this advocacy plan, and it's been extraordinary. You did mention that everybody viewing this call can actually weigh in. Both NAC and PQHH have action alert centers on their websites. It's free, it's easy to go to. You click on it and you actually have a pre-formatted email that can get sent to your member of the House and Senate, US House and Senate. So if people feel like doing that now, that really can help the industry. Thank you so much for mentioning that. Okay, so Evan, let's move on to you. So Evan, on top of the rate reductions, CMS finalized calculations for additional clawbacks of more than $2 billion for services provided to patients during the COVID-19 pandemic. We're hearing that more than 1/2 of all Medicare certified home health agencies in the nation will be operating under negative margins as a result of these rate cuts. So Evan, I know in your role as a state association executive for both Indiana and Kentucky and chairs the Council of States, you're hearing a lot in terms of what's going on the ground. These cuts could potentially impact 50% of your association provider members and likely similarly across other states nationwide. So how are you communicating with the other state executives at the state association level? What are you hearing from home health providers? And what plans do you have to ensure your members, the provider viability in terms of, educating them around this issue, around compliance, operational efficiency, and other things?
Sure, thank you, Deb. And Stacy already sort of touched on this. The state executives really have rallied around our national folks to make this a collaborative effort across the board. I mean, we're pretty much in lockstep and communicating as often as we can, because this is something that it's been, I don't want to say fluid, but it's been changing over the course of time, and we've had to just stay up to date with each other to figure out not only who we need to reach out to and have a conversation with, but also to make sure we're adjusting our talking points, to make it really clear what's happening. And I want to touch on that a little bit later for sure. So we're really staying in lockstep as much as we can to keep those communication lines open. Very similar to both Stacy and Michael mentioned, the HHGM, PDGM process. That was an important opportunity for us to really be vocal and try to lead the charge and make sure our members of Congress in DC were aware of what is happening, and that's really the call to action today, because despite all of our success up to this point, we still have a ways to go, as Stacy said, that we've got some deadlines we've got to hopefully meet before the end of the year. So we're all staying in very close contact to make sure that we have our put our best foot forward and have the best case we can to try to prevent this from happening the way that CMS has laid it out. And the reaction you're hearing it today, obviously from Michael and Stacy, and it's, it can be summed up in one word: it's just going to be devastating. I mean, there's no two ways about it. It's going to impact patient care. Michael already, laid out some numbers there, and our agencies are very much afraid of what this will do to their ability to keep their doors open and their lights on. And we already sort of touched on, the current challenges, today's challenges. Value-based purchasing coming out. That's been a big push for us from an association perspective to get our group ready for that in 2023. So when you add this on top of that, things are very busy. And that's not to mention all the other, workforce challenges, everything that's happening in terms of a daily effect on the ability of agencies to stay viable. So a lot of moving parts, and this, in some ways, and that's sort of how this works out, but couldn't have come at a worse time in some ways. So we're very much trying to prevent this from happening, and that's the mindset going into the end of this year. In terms of plans for viability and looking at compliance and operational efficiency, I think our thought on that from an association perspective is we've got to help providers be as perfect as they can, especially going into 2023, so they can set themselves up for success and be in a position that, let's say worst case scenario, and that's some of the planning, that being proactive, let's assume that these cuts go into effect, they're going to be able to absorb that cut and still maintain, some level of operation. So that's the mindset from the association, and that has a dual edge impact because, clearly we are impacted by our members' financial circumstances. So, we've got to double down on education and make sure everyone's ready. But, we also have some internal association effects of a move like this from CMS that we'll have to absorb. And as we're planning for 2023, that's already on the table. So it doesn't just, have that frontline operational impact. It's a really three-dimensional thing that's happening, and we're all very concerned about and very focused on.
Thank you, Evan. I appreciate the fact that your associations are always there as kind of the on-the-ground army to make sure that everything that's going on at the federal level on advocacy, things that Stacy was talking about and the impact that Mike was talking about, is getting addressed. So, we're hearing that CMS finalized these cuts despite strong opposition from patients, from providers, and actually members of Congress. Stacy said it wasn't their intent. So the 7.85% permanent cut equates to more than $1 billion annually starting in 2023 and finalized in 2024. This will result in devastating long-term repercussions for home health patients and their providers. So Mike, are Beata clients aware that reduced payment to providers may result in reduced levels of care or reduced access to home-based care? Tell us what you're doing in terms of addressing this from an operational, staffing, and patient care perspective. And how are you communicating this to your provider and payer partners, in particularly the managed care payers, as that's increasing?
Yeah, great question. So let me frame it first before I get into that, which is I think there's opportunity here. All right, so it's not all doom and gloom, but it is dire. Where is the opportunity? If payers and providers can agree that we're looking for the same thing, to keep people healthy, and in our industry, healthy at home where it's least expensive. So there's actually a lot more alignment between the payers and the providers, where historically, we've been sort of enemies on each side, and you duke it up every year for your COLA or whatever it happens to be. And that, we know how that game plays out. It's exhausting, and it doesn't get us where we want to go. And so I think there's opportunity for innovation here. That said, and I'll come back to that, but that said, for us, we don't have a conversation about a lot of conversations with our clients about the price of care, the cost of care, and the worry that it's going to go down. But we do talk to them about payment cuts, regulatory things, because the voice of the consumer, in this case the patient, is really powerful. So we do ask for their testimony and so forth to sort of speak to the value that they got from the services we provide. But the reality here is their Medicare premiums didn't go down. So their expectation of the level of service is going to stay the same. And if anything, the Medicare premiums go up. And so for them, they're not saying I'm paying less, therefore I should get less. I'm paying the same or more. And so this is where innovation comes in. We've got to figure out how to deliver and get the same outcomes, but doing it in a way that is more cost effective. So we engage with them around their care and so forth, and to tell the stories of why this is valuable. But it's really up to us to figure out how to get them what we think they deserve in terms of the outcomes. So that's one way to think about it. In terms of our our provider partners, health systems, physician practices, and so forth, they're sort of in the same boat, and so they're also expecting the same level of service. And so where I think there's opportunity here is if we can figure out how to do some things where we're at risk, we're sharing risk, right? Home health value-based purchasing is in some regards, right, getting towards, it's value-based purchasing. I guess you could, there's risk, there's upside and downside risk. So I think Medicare and CMS is heading in the right direction. But where I really think in the short term they can start to get innovative is expand the options that we have in terms of how we deliver care. I mentioned virtual visits and so forth. There's a lot of things that we could do to get the outcomes that they're looking for that aren't considered reimbursable or sometimes allowable in the current model. So if we're going to do cuts, let's use it. If we're trying to get more efficient, let's use it for a way to get more effective, right? Innovation. And I really do think this alignment with payers can be a real win. Case rates, other things that we could go ahead and do. So I think that's important. Maybe two more points. One is when we talk to payers, part of what the point I try to bring across is when you read MedPAC, right, who will consistently say that we're overpaid, that our margins are too broad. Okay, we could argue about what the right margin is, but what I try to remind folks is in other healthcare sectors, the federal government pays for some of the technology and some of the things that they need. So for home health, we had to pay for all of our EMR transition. Health systems and physician practices got dollars to support that happening, which I certainly appreciate. We have to pay for the innovation with telehealth and to improve care. I'm fine. That has to come from somewhere. So for us, we think about the bottom line as an important element because it is the funding that we use to reinvest back in the business and get more efficient and more effective. And so figuring out a way with payers to go at risk so that we have the opportunity to make more because we're going to reinvest that back in the business is a lot of the conversation that we have. And so what we're in CMMI would be a good place to really look at this. Let's get a home care consortium together and try some models with CMMI. I think there's plenty of opportunity there. We would be very, very open to that. What I do remind my colleagues of across the industry who are a little bit anxious about getting into risk-based contracts is, guess what? You're at risk just by being in healthcare. And we just saw that what the risk is. We got a 4 or 5% cut. Really, let's be honest about it. So wouldn't you rather have at least the opportunity for some upside, even if the risk of downside is lower or is higher? My answer is yes, because otherwise we're duking it out every year over COLAs while we sort of get cut. And so what I would encourage the providers on this call is be thoughtful about who you partner with as a payer. To me, it's less about work with the ones who pay you the most per visit and look at the ones that are willing to be innovative and pay you for outcomes. Get really clear on what those outcomes are so you can be truly attribute your efforts to those outcomes and learn. And what we're going to do is we're going to start to prioritize the payer relationships we have, managed Medicare, commercial, and so forth, with those folks who are willing to be more innovative and take risks with us. And if we start doing that more, then the conversation changes about the cut every year and what are we going to do? But it takes some technology. It takes a bit of confidence in your capabilities. But I think it's the right direction. Whether you do it individually as a small agency, you sort of join together. But I say approach the payer as a partner, not as the evil empire, which certainly how I felt about it when I first started practicing. As a clinician, I didn't think I should have to worry about payment at all. I really didn't. I'm embarrassed to say, but I sure wanted my paycheck every week. And so it's okay. I believe there's absolutely enough money in the system to take care of people, but not the way we're designing our payment models now. So how do we get innovative? And that's where I try to take this and use it as a catalyst to move us forward. And so I'm hopeful, but I'll leave it there and turn it back to you.
Thanks, Mike. I really like the way you were talking about innovation, thinking outside of the box, partnering with payers, leveraging technology. I think there's so much opportunity, not just in the home at the bedside, with telehealth, but also lean on your EMR vendors so that they can make sure that your agency is more operationally efficient so that you can navigate through this. So those are great comments. I really appreciate that. All right, so let's go back to Stacy. So Stacy, we're going to talk a little bit more about the rates and payments. So while the home health base payment rate cut in 2023 is halved, right? So we're getting a break there. CMS indicated that it will implement the additional permanent rate reduction in 2024. So CMS will also need to recoup the alleged overpayments for the 2020 to 2023, beginning as soon as year 2024. So the temporary payment reductions yet to be collected total almost $4 billion. So I know, Stacy, you were talking about the goal of PDGM, right? It's better to better align payments with patient care needs, especially for those beneficiaries that require more skilled nursing care rather than therapy. So what impact do you believe CMS's actions will have on your agency, Accent Care, and the broader home health community's ability to serve more complex patients as we're moving forward?
Yeah, thank you, Deb. I think, if you look at the whole premise of PDGM and why CMS, initially started with HHGM, and they had been studying this for a decade, right? This was nothing new. I mean, you could go back and look at reports from 2010, 2011, where, CMS was really starting to think about, a payment model focused on clinical characteristics, right? And so that's kind of was the birth of HHGM that became PDGM, was moving away from, therapy, utilization with, that was the payment system CMS gave us, right? We deliver care in the manner in which CMS provides, the payment for. They shift how they want care delivered through their payment model. And so, pre-PDGM, it was very therapy-driven service. So going into PDGM, and all the research going into it really wanted to focus on clinical characteristics and, and individuals, beneficiaries who had higher clinical needs. So wanted a payment model that would focus more on the duals, for example, right? They are, they have, many, multiple comorbidities. They are, a very expensive population. They are a very sick population. So that, one of the intents of PDGM was to focus on duals, right? And provide a payment model that would incentivize providers to deliver that care, that skilled care. And so then now you step back from, what CMS has now proposed in these kind of cascading cuts, and you kind of question, well, where do they think their decision and how they're calculating budget neutrality, how is that going to impact these patient populations that they were trying to incentivize care for? I think, providers like Viata and Accent Care, and, we're always going to focus on quality, and we'll always be able to deliver quality care, and that will be the standard. But I do think if you look at the system of how it's set up and wanting to focus on more complex patients, we're doing that already, but with workforce challenges, and it's pretty documented, it is centered around workforce challenges. We're not even able to convert the referrals to admissions that we're seeing right now under the current payment system, right? There's about a 20% gap between a referral and an admission. So as our health system partners have really relied on us to move these patients out of the hospital and into the home as quickly as possible, if we can't take these patients, then they end up either going home without care, they'll end up going to another type of post-acute care institutional facility like a SNF, or they stay in the hospital waiting for that discharge to home with home health. And it just gets putting a strain on the entire system. It's really fracturing it more so, I think, as much as it was under COVID, right? It's just a continuation of that. And so when you have these payment challenges, and as we are accepting more, complex patients, a payment reduction, is going to limit our ability to be able to take those referrals in. Like Michael said, look at the workforce challenges that we all are having, and so I think it's it seems very detached from the reality of what PDGM, the intent was behind it, and where CMS is going as far as a payment policy. And to touch on something that Michael said, it is referenced within the rule, and that CMS believes that the payment is adequate and sufficient, and they like to cite the MedPAC margin analysis. Just remind everyone that MedPAC's analysis on it's an aggregate, it's a fee-for-service margin, right? And it's it does include a lot of things that are not within the cost report. And when we talk about treating patients, Medicare patients, we talk about treating Medicare patients under fee-for-service and Medicare under Medicare Advantage. We are treating a Medicare population. And when you look at MedPAC's analysis of margins, that they don't publish a lot, or as much as they do the fee-for-service, for the past 5-6 years, total margins for home health range from 5 to 8%, right? And so there's just this downward compression on the fee-for-service side, right? And you don't have much room on MA, and so you're trying to navigate this of how you're going to take on these more complex patients, with CMS not really understanding, I think, the situation that we're in right now, or choosing not even to listen to how they're calculating budget neutrality. It's quite frustrating, but there's no doubt, like Michael said, I think innovation will be key. I think the advocacy to get this 1-year delay and getting to a more permanent structure. But I think providers like Axxess, Biata, and so many others will continue to find ways to deliver quality care. The strain will be whether we'll be able to take the referrals in that are heading our way from our health system and physician partners.
Thanks, Stacey. We're hearing across the industry that agencies are turning away referrals, up to 30-35% because they just can't handle it. And that was a little bit more during the workforce shortage, but all of these elements are also compounding that too. So thank you for mentioning that. All right, so let's pivot and go to Evan. Evan, elements of the final rule will hasten an already consolidating home health sector. So what are your thoughts about your state association's viability in the face of these challenges? I know you touched on it a little bit earlier, but isn't association membership and provider advocacy more important now than ever?
Absolutely, Deb. And our mission from a state association perspective, we really want to be out there leading from the front and really being proactive. And unfortunately, we also spend a lot of our time dealing with Medicaid cuts. Medicare cuts have been less frequent, but this one's pretty significant, pretty really an important advocacy effort that we're undertaking for all the reasons we've talked about here today. And we'll need to bring everything to bear. I mean, it's as simple as that. Everything, all the elements in our arsenal, we'll need to use all of those. And that is really what's at stake here for state associations, because our viability does depend on our members so much. So that this rule really puts the state association mission and viability at risk, and we'll have to use all the tools in our tool belt to try to get to a place where it's not going to have the impact that it's slated to have today. We often hear the phrase "no margin, no mission" in a lot of different conversations, especially in the nonprofit arena. And that's really where we're at from a mindset and framework for state associations, and that relies on our members' margin and their ability to remain viable. So again, situation really highlights all that, brings it to the forefront, and we're in a position where we've got to really be as aggressive as we can, especially, like I said, headed into the end of the year here. From an advocacy perspective, and I think Stacey and Michael would agree with this, it's more important now than ever, absolutely. And this is a moment, I think, I wonder what Stacey and Michael might have to say, but my immediate reaction to the rule was that this is really, we had developed so much momentum and we're at risk to lose all of that. It really invites us to be complacent. because you take that breath and you say, oh, we've got a year to try to figure this out. And I think what we're trying to articulate here today is, yes, absolutely, you have a year to plan, in terms of assuming that this is going into effect, but in the short run, we've still got a chance and a very good chance to try to prevent this from happening. And so we need to take advantage of that opportunity within the agencies. And I certainly don't say this as a criticism at all. There tends to be a mentality of, I've got to deal with today's problems today to keep the doors open, and that's 110% genuine, and we understand that from the state association perspective. And then hopefully I'll get to tomorrow's problems tomorrow. This really flips that on its head, because we have to deal with tomorrow's problem right now and do our best to try to prevent it from happening, and deal with today's problems. Michael and Stacy already articulated that. So we've got to do both, and it's really a call to action to and a challenge for us to try and accomplish that in the short window of time that we have here. And to that point about complacency, my other fear was this does enough in terms of strategy from a rule implementation perspective, that it also confuses folks that maybe weren't paying as close attention, whether it's members of Congress or their staff. So now we have to go and re-educate them, and maybe even in some ways start from square one, because we've got to explain that this isn't, Michael said it earlier, this is a cut. We got a cut. It's still a cut, even though we're looking at a 1-year reprieve, so to speak, or a 1-year phase-in. So we need to do that re-education and make those members of Congress have that immediate concern for the impact of the rule here. And it makes it more complicated, right? That we've got to explain, all right, it was one way before, now it's maybe a little different, but ultimately the impact on the agencies is going to be the same. So, that's really our challenge. And I think state associations are really ready to step up to that. But as Stacy said earlier, we really can't emphasize enough that you can take action now and really participate in the process to try to move the effort to prevent this from happening forward. So
yeah, and if I can just piggyback on something that Evan said, Deb, and something we've talked about, like just as Michael and others involved on the operations side, advocacy on whether it's in the state or in DC should be constant. And if you get into a stop go approach, you lose the momentum of educating members and staff along the way. This is it shouldn't be, but it's a complicated payment system, right, to the average person. Hospice is a pretty easy payment system if you think about it, right? But this is difficult, right? And especially when you go into these changes and, you start talking about budget neutrality and, permanent adjustments and temporary adjustments and behavioral adjustments, and it's crazy, absolutely crazy. And so keeping that constant dialogue open with your members of Congress or your state legislator if you're dealing with Medicaid issues, but that constant conversation, because it's helpful that they know how this is impacting you, not just when a rule comes out, but all along the way. There's also within this rule is that all agencies are going to have to provide OASIS reporting on all payers starting in 2027. I know the nationals, pushed back. We pushed back against that because it's really not. It doesn't seem necessary, and that's an extra burden. Now they extended that to 2027, but that's another thing that we're going to have to continue to educate members about. Congress intervened once before in this matter about all payer reporting. So we've got a little bit of time, but there are other things in this rule that, that kind of layer on top of just the burden that agencies are going to have to go through.
Thank you, Stacy, for kind of pushing through that call to action and reminding us of some of those other implications. But Evan, thank you too. And we really appreciate what's going on at the state association level. And you guys are really driving and pushing and elevating everything that the federal, it's happening at the federal level with our national association. So thank you so much. So we've kind of come to the conclusion here. I want to thank you all for sharing your perspective and your expertise. I do want to open it up just for a 30-second final closing thought from each of you. So Mike, let's start with you. You've shared a lot of thoughts. Just last advice for everybody watching us today.
Yeah. So two things to think about for those of you that are out there every day with patients counting on you that you could do right now, whether we got a cut or whether we didn't get a cut. And just to be clear, we got a cut, right? That's why I started with that to Evan's point. One is make sure that you are engaging the patients and families as partners. We should expect them to be part of the care. But as a physical therapist, as a clinician, I can tend to be a little paternalistic at times. Don't worry, I'll take care of you. It's really the coaching model. So we know that, but we really have to dig deep into that and set their expectations that you're going to be fine without me. And so doubling down on that. And the other is, don't forget, while I have lots of issues with our payment models, one of the things that CMS put in place was a framework for a continuum of care. So if you've got a home health patient that's being readmitted several times, maybe they need to be in hospice. Make sure they're in the right setting of care. You got a home health patient who needs a little bit more rehab services. Why do you keep them under Part A when you should maybe move them to Part B? So use the continuum as it exists. If you're a single site home health provider, find an outpatient provider that you trust, partner with them, find a hospice that you trust. If you have all of those services, make sure they're integrated. Those are things we should be doing, but this is an opportunity to just go back to some of the basics and make sure our patients are engaged. We're coaching them so they're not becoming dependent on us, and we're helping them move through the system as efficiently, as effectively as possible.
Great advice, Mike. Thank you. Stacey, on to you. Last thoughts.
Last thoughts. So because I've spent my whole life in, advocacy, I'm just gonna, for folks on this call who want to, call your member of Congress, 202-224-3121. It's a switchboard. So that's the Senate switchboard, but you can still get over to the House. And just weigh in with them, on how you feel about, the final rule, and asking, them to support a 1-year delay. And I think just in general, I think we should always remember that it's patients and families that are our North Star and why we do what we do. And, access to home health, hospice, HCBS, all of those services along the continuum are critical. We always have to remember that we are, treating some of the most vulnerable at end of life. We're trying to maintain quality of life, and whether it's Medicare or Medicaid. So I just, having to fight these battles with CMS is daunting and frustrating, but at the end of the day, it's to ensure that we have, plenty of access to patients and for our patients and families. But thank you.
Stacey. Okay, and Evan, on to you. Final thoughts.
Yeah, I think, I would just encourage the optimism that Michael, spoke about earlier. Use this as an opportunity, not only within your own organization, but to Stacey's point, to develop relationships, to call your members of Congress. And it doesn't have to be something that takes away from the rest of the things you're trying to do. Lean on your state associations, lean on the national folks, so that you can participate, still, run your organization, play the role you need to play, but definitely get engaged, because this isn't going to be the last time that we have to do something like this. And we'll be more successful next time if we use this as an opportunity to develop those relationships and then stay in touch, as Stacey said. It'll make your job as an advocate that much easier. And then, organizationally, you'll be hopefully heading off some of these issues instead of having to deal with a cut like we are currently. So just a few thoughts on how to look on the bright side of this and get the advocacy piece, where we want it to be.
Thank you, Evan. So I'm going to be wrapping it up. So on behalf of Home Healthcare News and Axxess, I just want to thank our panelists, Michael Johnson, Stacy Smith, and Evan Reinhardt, for participating, and to you, our audience, for listening to this webinar today. A link to the recording will be shared for on-demand viewing for those of you who have registered. Feel free to share that with your teams and people within your agency, have discussions about all of this. We did not take live Q&A, but if you have any questions for the panelists that you'd like to pose, please feel free to email me and I will ensure to forward your questions to the panelists for a response back to you. My email address is dhoyt@axxess.com. So thank you all. I hope this conversation was informative and helped you navigate through these changes that we're facing ahead. I really enjoyed this conversation. Michael, Stacy, and Evan, thank you to all of you. And to everybody else, have a wonderful day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.